Good afternoon. Welcome and thank you so much for joining us today for our webinar, All Hands on Deck, Integrating Infant and Early Childhood Mental Health Consultation and the Pyramid Model. We have two awesome presenters joining us today, Sandy Abzaradel from Orange County, California, and Tori Sproles from Bozeman, Montana. And they're going to introduce themselves in just a few minutes. But the agenda for our presentation today, or our webinar, is going to be to talk a little bit about mental health consultation and the pyramid model, sort of a introduction or orientation overview. And I'll be presenting that, but I'll be quick about it. Just making sure we're all on the same page and really, understanding what both mental health consultation and the pyramid model is. And then we'll have time for Sandy to talk about how her program integrates the two, integrates mental health consultation and the pyramid model, and to Tori to do the same. And they'll both be addressing, I know, some of the hot topics that many of you are interested in, such as funding and duration. And hopefully we'll have a little bit of time for questions and answers. So let's get to it. Actually, before we get to it, let me just introduce myself. I'm Amy Hunter, and I'll be facilitating this panel this afternoon. I am at Georgetown University, and I'm faculty on the Pyramid Model Innovations, who's sponsoring this webinar. And I also am faculty on the National Center on Early Childhood Health and Wellness, one of the TA centers for Head Start. So I'm very happy to be with you all today. And let's get started because I know we have a lot to go over. Okay, so first to talk just a little bit about infant early childhood mental health consultation. Mental health consultation pairs mental health professionals with people who work with young children and their families. And consensus in the field is that mental health consultants are master's prepared consultants. So that is the ideal. But why so much focus on mental health consultation? So, why would we have mental health professionals paired with childcare centers or paired with home visiting? Well, we know that there has been now study after study that really confirms that social emotional development, which is really synonymous with infant early childhood mental health, but that social emotional development is really the foundation for all early childhood development, cognitive, physical growth, health, language, and then of course, social and emotional outcomes in development. And we also know that there's approximately 10 to 15% of young children birth through 5 experience behavioral or emotional challenges. And so it is really important, and we have lots of evidence now that pairing a mental health professional to build the capacity of teachers, of program directors, of home visitors to support that social emotional development and to help address successful or respond to successfully challenging behavior when it does occur is really effective. So let's talk a little bit more about what we mean by mental health consultation. So mental health consultation is not therapy. It is not, about fixing children. It really is, as I mentioned before, the purpose is to build the capacity of those other folks, whether they're teachers, whether they're directors, home visitors, parents as well, helping them feel more equipped to support children's social emotional development, to really understand sort of the meaning of behavior so that when children are using their behavior to communicate, those who work with children, day in and day out have a better understanding perhaps of what that behavior means. Mental health consultants help other caregivers to create an environment where all children can feel safe and supported, making sure that that environment is responsive to individual children's needs, really helping those adults understand what individual children's needs might be. And sometimes it's easier when we're trying to define what mental health consultation is to really think about what it isn't. So it isn't, as I mentioned, therapy. It isn't direct service. It certainly does work with families, but it's not solely focused on families. It can be provided in center-based. It can be provided in home-based family childcare. It can be provided, and certainly a big model for mental health consultation is integrating it into home visiting. There are also models of mental health consultation in pediatric care settings, in child welfare. So really, whatever that natural setting is, where infants, toddlers, and young children are with their families. And so now I'm going to switch gears just for a second here and talk about sort of the pyramid model. And I bet many of you are very familiar with the pyramid model, but again, just making sure we're sort of all on the same page. The pyramid model is a evidence-based framework of effective practices. And this, as you see here, is sort of the model itself, really basically a public health model. Looking at those blue strategies are the universal promotion strategies, so strategies that all children need, making sure that all the environments are nurturing and responsive, high quality. And then the green section really looks at those targeted supports. So what might children who have some risk factors or some adversity, what might they need that might be a little bit extra? So these are things like really being very explicit about teaching feelings words or feelings vocabulary, teaching things like problem solving and conflict resolution, using lots of emotion words, just being very strategic about sort of how we teach social emotional skills. And then the tip of the pyramid, or the red section, is really targeted to very few children, especially if we're implementing the rest of the pyramid. Those are children who really need that intensive individualized intervention. That would be maybe a behavior plan might be developed based on observation, based on collecting data, really figuring out what does that individual child need to be successful, and what do the people who are working with that child need to really put a plan in place for that child and family. But one thing I didn't cover here is I kind of skipped over the yellow section, which is effective workforce. And what we know is that it's hard to expect staff to implement all of this when they don't feel they have the skills and the support to be able to do this. And so that's one place mental health consultation can come in addition to all the other sections, is helping staff to feel ready to adopt some of these strategies and supported and equipped. And so you see, the pyramid model is a framework for evidence-based practices. And then I want to just briefly talk a little bit about sort of the system of the pyramid model that supports implementation of those practices. And so we have here the elements that really guide that program-wide implementation. And we can talk kind of briefly about where mental health consultation can help support program-wide implementation. And so the pyramid model, we want to make sure there's a leadership team that guides those effective practices, those pyramid practices. The mental health consultant might be on the leadership team. We want to make sure that staff is buying into these pyramid model practices so that they have an understanding of why would I use these practices? Why are these practices effective? Is it worth trying to adopt something new? Why would these new strategies be worth my sort of investing in? And of course, the mental health consultant might be able to help staff understand more about the practices and buying in. And family engagement, we all, I think, would agree that families are their first and most important, children's first and most important teachers. And so perhaps the mental health consultant can help really support the programs to have a very strong family engagement component. Program-wide expectations, we know that the pyramid model is most effective when it's adopted program-wide, so that if a child moves from one classroom to the next, they know that the expectations are the same, they're clear, they're developmentally appropriate, and that all staff is on the same page regarding those behavioral expectations. And similarly, we want to make sure that the program adopts procedures for responding to challenging behavior, and that those procedures are program-wide, so that everyone in the program knows, sort of what the system is for responding to children with challenging behaviors. And next, going around the circle there, we're talking about continuous professional development and coaching. So you will hear from Sandy and from Tori different models of, whether there's a coach and a consultant, or the consultant sort of serves in the coaching role, and how the mental health consultant might provide professional development in some cases. So there's certainly different models of that. And then lastly, making database decisions. And so really thinking about how the program collects data, what kinds of data they collect, and how they use the data to really make continual improvements and adjustments, and looking at the data to see what it's telling them about outcomes for their children. All right, and you can see that mental health consultants could be involved in each of these sort of slices of the pie, or each of these elements. And now just kind of shifting gears a little bit back to mental health consultation. But I wanted you to see how sort of the program-wide pyramid model and mental health consultation, programmatic mental health consultation, sort of fit together. So we often talk about mental health consultants engage in sort of 3 types of consultation. So child and family, and that's really where the mental health consultant is supporting a program or a teacher around a particular child or family's needs. So one child, one family, and their concerns or others' concerns related to them. Classroom consultation, so that would be where the consultant would be talking with teachers about the whole class, sort of what are the classroom rules, what are the routines, how are transitions, how are they teaching those social emotional skills, how are they teaching conflict resolution, how are they teaching those feeling words, sort of all of those things that apply to all children in the classroom. And then programmatic is where consultants are working with the program administrator. So maybe the program director or somebody at the high level in the program, really thinking about what are those policies, what are those practices, what are the program-wide expectations that support children social emotionally and that address challenging behavior when that does occur. So we know that mental health consultation is most effective when it addresses all 3 of these levels sort of at the same time. And then finally, just kind of, and this will be our theme for the rest of the webinar, but thinking about the integration between having a mental health consultant and implementing the pyramid model. And so the mental health consultant can really directly support those strategies, those pyramid model strategies, through coaching in some instances, or through working with coaches in some instances, through providing professional development, through just integrating those practices into their conversations. Mental health consultants can supplement the pyramid model. So if there is a coach already in place, maybe the mental health consultant is bringing some additional topics into the conversation. So for instance, maybe a trauma lens, or talking about parental depression, or talking about staff wellness, or some other pieces that might supplement the pyramid model implementation. And the message here that you're going to hear probably over and over is that these are challenging situations often, and we really require, ideally, all expertise, and really putting together the different lenses and different expertise to make the most successful care for our children and families. Okay, so that was my very quick overview of mental health consultation and pyramid model. Next, I'm going to have both Sandy and Tori introduce themselves, and then we'll move on to them talking a little bit about their program models and how they incorporate both mental health consultation and the pyramid model. So Sandy, let's hear a little bit about you and your program.
Great, thank you. And thank you for having us out here on the West Coast doing this webinar for you. So my name is Sandy Abzeradel. I have been with the Early Childhood Mental Health and Wellness Program. We implemented our first program in March of 2018. So we are almost to 2 years, and we have served a wide variety, up between 36 and 43 programs that we've served. So I'm happy to be here today and help everyone understand a little bit more about how we integrate the pyramid model and infant early childhood mental health consultation here in California.
Thanks, Sandy. And next we have Tori. Tori, why don't you introduce yourself and tell us a little bit about your program?
Hi, and thank you for letting me participate in this webinar as well. We have been, my name is Tori Sproles. I'm the Professional Development Coordinator here at our local Child Care Resource and Referral Agency. And for the past 5 years, we've been lucky to have the Project Launch grant. And so part of the Project Launch grant is to incorporate mental health services into early childhood settings. And so we've been able to do that. So that's been really exciting, and I can't wait to tell you how that's all rolled out.
Great, thanks, Tori. So Sandy, this is you. Tell us a little bit more about your program in Orange County.
Sounds good. All right, so the Early Childhood Mental Health and Wellness Program is one program that was designed out of the Early Childhood Mental Health Collaborative. And you can see here on the screen our collaborative partners. So here in California, we have Prop 10 money, which is the tobacco tax use. And that is all of that, the funding goes to programs and services from birth to age 5. So First 5 Orange County gave us some startup money to design this program. And then Chalk Children's Hospital has been our main funder. Their private foundation has funded this program, and we are working to include some public dollars in that as well. Children's Home Society of California, they are on our collaborative and do some referrals to our program. Same with the Regional Center of Orange County. So if children do not qualify for special education services through the Regional Center and they're demonstrating challenging behaviors in their child care program, oftentimes they'll refer them to our program so we can help support them within their setting. Orange County Department of Ed is another huge collaborative partner. We work very closely with their quality rating improvement system coaches and their pyramid model coaches as well. Social Science Research Center did some original research for us to get some baseline numbers, and they will be ongoing and looking at, we're hoping to do another 5-year look at the data and see if, well, not if, but we will have seen improvement, I'm sure, in our social emotional development of our young kiddos here in Orange County. And then the Orange County Association for the Education of Young Children, which is part of NACCE, and they sit on our collaborative as well. So our program, like Tori's, combines the infant early childhood mental health consultation model, and we use the pyramid model practices to help support the staff there. I think the main difference is we don't have a wide pyramid model implementation in Orange County. We have training that our Orange County Department of Ed does, and they can support programs with the pyramid model practices, but it's not implemented on a county-wide scale. So what our consultants do is using that 6-step process of the initiation, needs assessment, collaborative action planning, you can read that. Using that process, they embed pyramid model practices within that process. So our needs assessment is all determined using data, and we use the data tools that are part of the pyramid model. So the benchmarks of quality with the cultural companion, we use the teapot and tippy toes, we use prevent, teach, reinforce for young children. So through that process of the consultation, through each of those steps, we're using the practices and the tools and resources of the pyramid model. So our role is really to support the capacity building of the staff. So as you said, Amy, we're not working directly with the children, but rather working with the adults who are working with the children to support them within their role. And as we don't focus necessarily on the parents, if we are working at an individual child level, then we automatically bring those parents in to support the individual behavior plan and work as a team. We will also go out into the home, do home visits. We will do the prevent, teach, reinforce for families if necessary. And we will make sure that those parents are really on board and have the tools and resources necessary to support their children at home as well. But our main focus is really in the program. So you can read on there that we're constantly bringing in all the tools from the pyramid model, but our role is not to scale them up on the pyramid model, but rather give them all the tools and resources necessary to support their work. I just do want to mention our referrals come from community-based organizations around the county, as well as the regional center and Children's Home Society and Help Me Grow. We have a Help Me Grow, very robust Help Me Grow system, which is a resource and referral system for children birth to 5. And we will oftentimes get referrals from them to help support the staff at the child care provider.
Great, thanks, Sandy.
So just a few logistics. As we have implemented since March, we've been in 36 family home child care programs as well as center-based. We do try and support the programs that do not receive state or federal funds because they do not have access to this type of support. So we try and prioritize those without state or federally funded. The program is at no cost to parents or providers. It is all through our private foundation grants. We provide anywhere between 3 and 6 months of on-site support, and we require a minimum of 1 hour a week and a maximum of 3 hours a week. And we found that that is kind of our sweet spot in that programs, if it's less than an hour a week, they tend not to have the momentum kind of stalls a little bit, and the enthusiasm and excitement of this change and growth stalls. If we try and do more than 3 hours a week, oftentimes the staff start to rely on the mental health consultant, as opposed to what our goal is to scale these providers up so that they have the tools and confidence and competence and skill set to be able to do this on their own without the use of an outside consultant. our whole focus is about sustainability, fidelity to the practices, and sustainability. We want to transition out of their program, and they feel confident that they can do all of this on their own with minimal support from an outside consultant. We also implement ongoing monthly communities of practice. So our consultants, whomever they are working with, whatever programs they're working with, they do both an in-person communities of practice, and they also have the option to do a Zoom meeting so that those who can't get to that in-person communities of practice also have the opportunity to engage in that. And we do that monthly. And I talked about our priority of non-federally or state-funded programs.
Great, thank you, Sandy. This is, I know, one of the biggest questions we have heard is about duration and intensity and sort of finding that right mix, which, you know, the research really isn't there yet in terms of knowing, you know, how long is long enough, how long is too long, is there such a thing as too long? And so for you to share what you found in your program, I think is really helpful to others trying to figure these important questions out.
Yes, yes. And that was, you know, through really working through and collecting data and feedback on, did you feel supported enough? And then looking at the fidelity checks that are embedded through the pyramid program and the infant consultation model, and seeing, are they doing these to fidelity without our, you know, our ongoing hands-on support.
That's great. Thank you very much, Sandy. Sure. And now we want to hear a little bit about sort of more the details of the program from Tori in Montana. Take it away, Tori.
All right, so as I mentioned, we had funding through Project Launch for the past 5 years, and part of that was to have a pilot program for early childhood mental health consultation within early childhood settings. So unfortunately, our funding ended at the end of September. And so right now we are functioning with a little bit of an extension through Launch and some just local dollars to keep this going. But yeah, we've learned a lot. So our model, so this is kind of one of the visuals that we use to differentiate the role of the consultant and the coach. Basically, in our programs, we have 8 programs that participated in this pilot and are continuing to participate in this pilot. And in these 8 programs, they all differ from different types of programs. So we have family childcare programs that only have 1 caregiver and 6 children. We have group childcare programs, and then as well as centers. So we did want to get kind of a wide variety of programs to learn how mental health consultation and pyramid model coaching works together. So we have this pyramid that you see on your screen that we've kind of used to identify at which levels of the pyramid, how the consultant and the coach are interacting in these programs. This handout is also available within the resources at the end of this webinar, so you can see it a little bit better in your own time. But basically, we have a huge emphasis on, and as Amy said before, a huge emphasis on the provider. So the childcare provider, the teacher, the staff. One of the things that we felt like with pyramid model coaching that we could not always tend to very well was that workforce development piece. In the state of Montana, we have a quality rating improvement system called STARS, which does have a coach, a pyramid model coach attached to it. And so all of these programs that participated in this pilot are part of STARS. So they have their pyramid model coach, and then we gave them a mental health consultant. At the point of this inception of this program, we didn't have any criteria of how to really onboard the mental health consultants. So we just kind of handed them to these programs, and the mental health consultants started working in combination with the pyramid model coaches, and we kind of learned as we went. So here's what we've learned. So these levels, this is kind of what we've I divided out the resources, the expertise, and so that's kind of helpful. But the workforce development piece is where I want to start, is because we spend the first little bit of time working with programs on burnout and self-care, staff retention, that type of thing. So we do use the Maslow burnout inventory with staff to identify some of those things within just personal individual childcare providers. We actually have found that very helpful. We've identified some specific needs of staff that we would not otherwise been aware of, and therefore we're able to help them build some resiliency, build some capacity to deal with some of those things in order to be able to serve the child and the families better in their care. In addition to that, with that, they were met with each individual childcare provider and talked to them about their burnout inventory, talked to them about kind of some of their needs, so on and so forth. The cool thing about our pyramid model coach is that they definitely really do focus on implementation of pyramid model strategies. So that is a very strong support for these programs, is that it goes by each level and it really does follow the systematic foundation of each of the pyramid model trainings, as well as all the strategies built into the pyramid model. So then the mental health consultants just kind of support that. Our mental health consultants have been able to bring in that trauma-informed lens that we've never had before. All of our pyramid model coaches are early childhood trained, so they have the early childhood background, but not necessarily that mental health piece. All of our mental health consultants are LCPCs or LCSWs, so they're clinical with master's degrees, as Amy had mentioned before. And so they do come with that specialized lens for trauma and working with people through some of those types of things. So we do provide all three of those supports that Amy mentioned before. So the child, family, the classroom, the programmatic. Our mental health consultants have been involved with leadership teams at the staffing level. They've been involved with having conversations with families around screenings and developmental assessments, those types of things. They've been involved with just overall global kind of supports of children through either personal traumatic events or just overall classroom behaviors, those types of things as well. I wanted to mention duration, because that is definitely one of the hot topics and things that people really want to know about. The duration of our mental health consultants and how much time they're spending in the program varies depending upon the size of the program. Our family programs that only had one caregiver were really only receiving about 1 to 2 hours a month of consultation in addition to their pyramid model coaching, because they're just one person. So it takes a lot for them to, you know, get away from their program and have time for these meetings. And then our group and center-based programs were anywhere from 6 to 8 hours a month. So if you break that down, about 1 to 2 hours a week, depending on the size of the program. But that's kind of where we found our sweet spot. It ebbs and flows because things happen. We actually had quite a few programs have some traumatic events with individual families or programmatic traumatic events that have caused our mental health consultants to be very busy during those times. But for the most part, we stick to that about 1 to 2 hours a week. I want to make sure that I do mention that we do have another resource that we added to this webinar too. It's a video that kind of shows the one program's journey through mental health consultation and pyramid model coaching, and kind of talks about how they work together and what supports they have. So I encourage you to watch that if you're interested in doing so. But collaboration is our main piece here. I think that has been the most effective part of mental health consultation being in early childhood sites, is that our pyramid model coach and our mental health consultants meet regularly and collaborate on how they're going to support the childcare program as a whole. So you can go ahead and switch to the next slide and I'll talk about a little bit of that. So we have kind of three people that are providing supports for these programs. Like I said, all of these programs are part of our quality rating improvement system. So they have a consultant that comes with the quality rating improvement system, which is myself at this point. They have a pyramid model coach, and then they have the mental health consultant. So all three of us meet every 2 weeks to discuss how to support the program in a way that will not overwhelm the program, but will also support everything that they need. Also, the mental health consultants do meet with a clinical mental health professional for reflective supervision, which we feel like is a really important piece, so that they have time to also debrief about what they're seeing and talk about some of those types of things. So those are really important things. I would say our main takeaway from our pilot, and as we continue to do this work, is that programs do need to have some readiness in order to receive mental health consultation. We have learned that just handing them a mental health consultant was a little bit sticky, and it didn't work out as well as we had hoped. But as the time went on, we've been doing this for about 2.5 years. As the time went on, everything smoothed out, and peer model coaches and consultants were able to identify their roles better, and the programs were able to really set some goals and things around the 2 specific supports that they have. Going forward, we have started to do, excuse me, some more readiness type things. We want the programs to have a leadership team in place before mental health consultation begins. We want to make sure that they have pyramid model coaching consistently, which launch really did put some intensive coaching into play just as part of launch in general. But we do want to make sure that they are getting that consistent coaching, and our consistent coaching for pyramid model is about at least meeting with the coach 2 times a month, every other week if possible, but at least 2 times a month. And so they're doing that, as well as, you know, just able to have, excuse me, the time to meet with a consultant, building in that time for the support for the staff and for the director to have really set aside time to meet. That is one of the hardest things for providers, is to have staff coverage and that kind of thing to meet with a consultant, but we have definitely found that very, very, very effective. And then again, I'm going to say this until I turn blue, but the collaboration piece has been huge. We would not have been able to support these programs wholly without having all of us constantly communicating about the needs of each of the individual programs. So I feel like it's been really, really beneficial, and we've learned a lot from this 2.5-year model, and going forward, we plan to continue, and hopefully we can.
Great. Thank you, Tori. You really touched on a lot of things that we, again, hear so many questions about. You know, you both talked about duration. You also talked about the idea of readiness, and really thinking about sort of what does it mean for a program to be ready, and or does a program have to be ready? And I appreciate your perspectives on that. You also mentioned reflective supervision, which I know comes up quite a bit. Of, you know, there's been clear consensus in the field that mental health consultants do need to have reflective supervision to support them to do the work of supporting others, right? That parallel process. But there often is a lot of question about sort of the differences between those things. But I appreciate you making sure that that was stated as part of your model for consultants.
Well, and just to reflect on that too, as we kind of move consultants out of programs, because when we first started this pilot, we had no intention of necessarily cutting off mental health consultation. We didn't have a duration as in time, like 6 months, 3 months, that sort of thing. And as we kind of move forward, we do have a little bit more of that understanding. But when programs are kind of moving out of the consultation model, we are then training programs how to do reflective supervision with their staff, because we feel like the mental health consultants have been kind of that person for the directors specifically, mostly. And so we're trying to get the providers, the directors of the programs, to be able to provide reflective supervision to their staff once we're no longer there.
Oh, that's great. I'm really glad you explained that and your vision for how that's going forward. It really, all of what both of you have been talking about, and I know we have more to go, but is really supporting the idea of this capacity building and sustainability, right? You know, so what is it once the consultant sort of works herself out of a job? What are the pieces that are in place that allow this to continue, you know, allow this reflection to continue, allow, you know, even if there's new staff coming on board, we know that in childcare there often is turnover. And so what's in place in terms of that capacity building that allows, you know, folks to really continue to do their best on promoting social emotional development and understanding child behavior. I'm going to switch gears just a second here because I know we don't have a lot of time, But I was just talking about the sustainability and then also funding. We certainly hear lots of questions about how these programs are funded, and we know across the country, each model is unique in how they set this up and lots of different funding sources. So Sandy, do you want to say just a little bit, and I think you covered this already, but maybe just highlight a little bit of your funding and sustainability plan?
Yes, yes. So since the inception of our program, we have always wanted to have a public-private partnership in terms of funding and sustainability. So we are in the process of pursuing Mental Health Services Act dollars, and looking really positive. I'll just say that. But we know that with grant-funded monies, grants end, and so we want to make sure that we have a robust private funding stream as well, which is where our Chalk Children's Hospital, we are fortunate that they have really embraced the early childhood mental health concept and understand that that is the most upstreamist. If we fund at those very early stages, then we are going to prevent a lot of things from happening later on. So that's our goal. With sustainability, again, our goal is to make sure that our providers are doing these practices and can do this on their own, so that we can go out and support the other. We have over 3,000 family child care and center-based programs that are non-federally or state funded. So there's a lot of work to do. But what we want is for them to be able to, the programs to be able to train their staff, like Tori was saying, to do this on their own and to do those practice-based coaching sessions, so that their staff, if and when their staff move on to other programs, they have that workforce capability to implement this. We've had a couple success stories with that, with providers who have left their programs and started their own programs. And so they are then taking this on and sustaining it. So that's kind of our growth. We've also had it with children, where children have left one program and gone to another. And then we've been working with that program, and they are using the language of the social and emotional language. So that is also another piece of sustainability, right? But Orange County Department of Ed is our main collaborative partner. They provide all of the training for any of the staff that we're working with through their QRIS programs, free of charge for our providers that we're working with. And we're also working together to define exemplar programs, programs that have gone through all of their 4 tiers of pyramid model training and that have worked in our program, so that we can utilize them not only as model preschools for staff to come and see, but also then hoping to have 2 or more programs within every region of Orange County, so that if we have some kiddos who need to leave a program because it's not the right fit, we have places that we can propose to the family to get the support that they need. We also utilize our community-based organizations a lot to provide family therapy, individual child therapy, and then a big piece is Chalk Children's Hospital does all of our clinical evaluations. If we get to the point where we need some clinical evaluation and service, Chalk Children's provides that at no cost.
Great, thank you, Sandy. I know you're really being specific about the types of funding and the diverse range of funding helps other people in other organizations and communities really think about what might be available in their communities.
Yep. Yep.
And so Tori, how about your funding? And you've alluded to it's shifting, or it is in the process of shifting, but if you could share just a little bit about that.
So our story is pretty quick and simple. Launch funding obviously is going to be ending soon, that extension, but we do have launch funding now for the next few months. Once that ends, we are hoping to have just some community funds from Child Care Connections and our health department to hopefully continue consultation through September 30th of this year. But then We are just constantly writing grants and trying to figure out how to sustain it. Pyramid model coaching is going to be sustained because it's through our quality rating improvement system, so that's not going anywhere. But mental health consultation is something that we've been trying to grants for. State, our Early Childhood Services Bureau is committed to and trying to find funds to keep it going. However, some of our programs are very invested and really want to keep that support in their sites, so they've tried to figure out how to sustain it themselves as well. Part of our built into it, so they do actually get some monetary incentives for participating. And so with that being said, some of them have decided that if this is not funded from other entities, are using some of those incentives to be able to have that support for their staff. So there's positive things. We're optimistic, but no long-term funding sustainability at this point. As far as sustainability of just the services, the coaches will continue to work with programs until they don't want coaching anymore. And we are, like I said, trying to transition those programs with the mental health consultants and working on reflective supervision and some sustainable strategies, so that when the mental health consultants aren't there, they're able to do some of those things as well.
Great, thank you, Tori. Next and kind of last in terms of the topics for both your programs, can you each share just a little bit about, I know we're sort of in the home stretch in terms of time, but a little bit about data and outcomes, and I know it may be a little preliminary, but just giving us a flavor or a taste of what those are. Yeah, thanks, Sandy.
So we utilize a lot of the tools. So we have kind of a two-tiered data and outcomes evaluation. One is the internal program data and evaluation that we use so that the programs can see the growth that they're making. But the second tier is our program, making sure our program is doing what we intend it to do. And our preliminary data has shown that programs are making improvement. It's easy to replicate. So meaning that going from program to program, we have all of that intact so that we can replicate it without a lot of funds. That's a huge piece of it. But we are seeing an increase in social emotional skills of the children. The biggest piece, I think, is a decrease in programs calling parents to have them picked up for challenging behaviors, and a decrease in the likelihood that they'll remove that child from the program, which is our goal, right? We want to keep them where they're at. And so we're seeing really good outcomes right now. Next steps are, like you mentioned, Amy, is looking at this hybrid program of infant early childhood mental health consultation and the pyramid model, and seeing how that works together and what outcomes we're having with that. So we're looking at expanding our evaluation a little bit.
Well, we can't wait to hear the results of that, right? That is sort of the next frontier, is figuring out what parts are most effective for what, and what do you get if you put these things together.
Yes.
Tori, I think you were going to talk just a little bit about some of your data collection.
Yeah, so quickly, in the essence of time, these are just some of the things that we've used for data collection. Like I told you, the MBIs we've used satisfaction surveys to figure out how mental health consultation is being viewed from the early childhood settings perspective. Also, on that, we use ages and stages questionnaires, so ASQ, SE2, and then we have used some DECA as well. And then just lots of testimonials too. We've had many success stories as far as how mental health consultation has gone so far. The next slide is basically just some preliminary data that we collected. It's been a while now. We have much more data now, and it's actually coming together in a nice little report after launch closes. But we've just seen overall that mental health consultation and pyramid model coaching in collaboration has been very, very beneficial to programs. TPOTS and tippy toe scores have gone up, and that's really exciting to see, as well as we use the environment rating scales and things like that in our stars to quality programs, and we've seen those things improve, as well as our star levels in our programs have improved quite a bit, just with all of the support that's happening. Staff retention has been better. We have definitely seen a lot more supports for staff, and so therefore staff is definitely staying longer. Longevity is becoming a thing, which is great because we know how much turnover is in the early childhood field. And also on Sandy's note as well, we've seen a lot less, almost none, expulsions and suspensions for challenging behaviors, which I think is very exciting. So I get goosebumps, but long story short, it's definitely been a very positive experience for our community, and therefore we are really hoping to continue.
I have a big smile on my face hearing all of these exciting outcomes and the passion that just comes through from both of you on this. Just to summarize, and I know that both those of you who are listening, you probably heard things from Tori and things from Sandy that you want to hear more about, and you can feel free to email questions or get in touch with us. As Tori mentioned, there's some resources in the resource section, but feel free to ask questions and we'll get you in touch, or we'll answer your questions for sure. But just to sum up some of the themes that you've heard, these multiple lenses that aren't so different, that are really often very overlapping, but that bring in, slightly more focus on, one aspect of the work or the other, are really beneficial. And I think you've heard these testimonials that when combined, it's really effective. And that the children that are often in our programs that we feel challenged by are often really complicated situations. And so the more help that we have, the better. And those programs that have pyramid coaches, I think you've heard sometimes the coaches get stuck. And so to have that additional support and that collaboration that both Sandy and Tori talked about can be really helpful to the coaches as well. And there's never enough support to go around. So really thinking about how these two pieces of support can really boost even positive outcomes that already are existing. And here is our contact information. Please don't hesitate to email if you heard something and you want to know more about it, you want more details. I know we all will be happy to respond.
All right, thank you so much to our panelists for their wonderful insights. Your feedback is very important to the work that we do. Please remember to provide your feedback on this webinar with our post-webinar survey by typing the web address shown on this slide into your web browser. Your certificate of attendance will appear once you submit the survey. We invite you to visit our website, challengingbehavior.org, to sign up for our upcoming webinars, access recordings, download pyramid model resources, and much more. Thank you to our funders for making this training possible. This concludes our webinar. Thank you all and have a great rest of your day.